Dear Jean-Claude, dear Josh, thank you for these nice words. I'm happy to be here and to speak on by sure, the most commonly missed cardiac anomaly, which is the total anomalous pulmonary venous return. First of all, if you look at the veins in the neighborhood of the heart, we have the superior vena cava, the inferior vena cava, the azygos vein, but we have 4 pulmonary veins with the coronary sinus here. And these 4 pulmonary veins we see almost on 2D, 2 of them just near the left atrium, but we don't see them because they are embedded within the lung. So their visualization on ultrasound is a challenge. And even if you write in many guidelines since the mid-80s that once you look to the 4-chamber view, you may see the pulmonary veins entering the left atrium. The prenatal diagnosis of the anomalous pulmonary venous return is still very rare. So you can see on 2D here how the 2 inferior pulmonary veins can be seen, but in general, we are using color Doppler. We say that on a routine scan, if you look at the heart, you need to see at least 1 vein, which is very important. But if you find in a fetus a complex cardiac anomaly, you should attempt to see all 4, which is still, in general, a challenge, especially in the mid-trimester. So if you want to see the 2 on the same side, you may need to get an oblique view and to see here the superior and the inferior pulmonary vein on color Doppler by lowering the peak velocity and decreasing the filter as well. So if we look at the frequency of this anomaly I'm going to speak about, and looking for the Baltimore-Washington infant study performed in the 80s, out of 4,390 congenital heart defect, there were 60 cases, which is a prevalence of 1.4%. So when you see this, you are really scared because it is more common than common trunk, than corrected transposition, than Epstein anomaly, tricuspid atresia. And I am sure many of you have seen these conditions, but very rarely have seen isolated total anomalous pulmonary drainage. So if you think you have never missed, I'm telling you, there is only one way: don't have a true follow-up, because many cases are not detected just after birth, especially when they are partial. So if we want to know the true numbers, and this is a very nice study published a few years ago in the White Journal, where you see here Helena Gardiner was a co-author of it. 19 cardiac centers in UK, Ireland, and Sweden put their data together and checked children and fetuses, but mainly children, where abnormal pulmonary venous return were evaluated without aneurysm or single ventricle. There were 424 children with this condition, and guess how many cases were detected antenatally? 1.9%, 2%. 2 out of 100 cases are detected antenatally. And this has only one advantage, that people invite me to give a talk today, but there is otherwise no advantage of missing these conditions. This is why we should know how to look for this condition. In general, if you look at the additional data, there were in 6 additional cases detected, and interestingly, there were in 17 out of these 422. The relative with congenital heart defect means the patient came with a high risk, and still the condition was not detected. So in order to recognize this abnormality, we should know what kind of patterns do we have in order to know how to seek for. There are in general 3 kinds of TAPVC. What is called the cardiac type. As you see here, there is this is a view on both atria, a confluent vein behind the heart, here emptying or connected to the coronary sinus, leading to its dilation, and the coronary sinus drains into the right atrium. This is called the cardiac type. There is the supracardiac type, where behind the heart there is a confluent vein, and through a vertical vein into the innominate or left brachiocephalic vein, draining into the superior vena cava and then into the right atrium. And there is the infracardiac type, where you find behind the heart a confluent vein which drains, and this can be explained embryologically, into a vertical vein crossing the diaphragm and going into the liver, into the portal vein. In general, these are all associated with a kind of obstruction, because the liver is such a less strong organ that the veins are obstructed. So this is probably the most dangerous condition detected antenatally. So if you look at the distribution, we have supracardiac, cardiac, and infracardiac with this distribution, but you'll see later on that some will find more supracardiac cases than the other one, and more than 50% probably. But there are other classifications as the total and the partial abnormal pulmonary venous return, or from the clinical impact, the obstructed and non-obstructed, but I cannot cover all these conditions today. If you look at 10 years ago, when Emanuele Valzan-Giacomo put data from 2 centers together, she reported on 16 cases with a mean detection at 27 weeks, 12 TAPVD and 4 scimitar syndrome. I will not discuss this condition today. Out of the 12 total, there were 8 with isomerism, 2 had infracardial, and 2 were hypoplastic left heart syndrome. But interestingly, out of the 12 cases, 11 had a confluence vein behind the heart and the vertical vein. So this is an important hint. And I cannot show you today all data published, but there are mainly some case report and small series found in the literature. So what you want to hear from me today is how to detect TBVC in the fetus and what are some hints to find this condition. You have seen that in the data I showed you that isomerism is a main hint. So if you find especially a condition where you assume it is right isomerism, you should check for TBVC, because I'm sure this would be the first case you have seen if you haven't seen before. So in 70%, 3 out of 4 fetuses with right isomerism, they have an abnormal pulmonary venous drainage. If you find an abnormal situs, before saying the situs inversus, check for the possibility of the presence of isomerism. If you find a condition like an AVST or single ventricle, this is also a typical, these are 2 typical cardiac defects found. If you find a dextrocardia, it can be associated with this condition, but also the shifting of the heart can be found in a scimitar syndrome for a partial abnormal pulmonary venous drainage as well. Another venous anomaly can be also a hint. The second hint is because all the three patterns I showed you, the cardiac, the supracardiac, and the infracardiac, had behind the heart a kind of confluent vein. So seek for a confluent vein because it's a common finding in this condition. That means you should not focus on the heart, but check the area behind the heart. And one could be subtile, which is a small left ventricle or cardiac disproportion. And this is why I recommend you to add to your referential diagnosis of ventricular disproportion not only the physiologic one and the coarctation, but also the abnormal pulmonary venous drainage. And if you look at this last year published paper from the US, from California, from Anita Mood-Grudy, you will see here that in 11 years, they found 26 cases identified. 22 had heterotaxy or cardiac abnormality, and 4 were isolated. And in this group, 18 were supracardiac, 1 was cardiac, and 7 were infracardiac. And almost all had a venous confluence. This is why it's an important hint. I want to emphasize it in this talk. And other, like cardiac asymmetry and vertical vein, were more or less present, but not very efficient. And abnormal pulmonary vein Doppler is an important hint, but this is nothing done routinely, but only when you have a suspicious case. So how to detect this condition, the fetus? I told you that one of the major key is once you have a suspicious case, check for the confluent vein behind the heart. So, and you see here what I'm telling you. This is the confluent vein behind the left atrium, and the shape of the left atrium changes. Now, if you look at this 4-chamber view, I'm sure 20 years ago you were happy to see, oh, this is an abnormal heart. It is single ventricle. 10 years ago, you were focusing on recognizing whether you have here a small chamber, is it the left type or right type? But I hope that today, in this era, you know that it's a single ventricle. We don't need to spend a lot of time, but check behind the heart, because single ventricle is a major hint for the presence of this confluent vein. So this is here one picture on 2D, and in my experience, 2D is often very easy in comparison to color Doppler, which may be difficult to manage. At one of the meetings, Dr. Kawatsu from Japan presented a new sign, what you can use. They had 1 case diagnosed prenatally. They add to it 7 cases missed. And what they found is that the distance between the wall of the left atrium and the descending aorta is larger than the aortic diameter in these cases. So this could be a hint, as you see, significant. But you have to think about, and as soon as you look at the area behind the heart, it may be helpful. So you see here, this is the area, this distance is larger than the aortic diameter. And you see here that these vessels are not connected to the condition. What I would recommend you, and what is recommended in the paper of the large European study, is that if you have a suspicious case which is likely to have an abnormal pulmonary venous drainage, check this condition later on in gestation, third trimester, because you have better images than at 22 weeks. So you see here an example at 19 weeks. The stomach is on the left, the heart points to the right. And you know it is very likely with this single ventricle it could be an abnormal pulmonary venous drainage. And do you really think that you will recognize this as an abnormal vein? No. There are two things you can do. You can ask the patient to come later on, or you take a high-resolution probe or transvaginal probe, even at 19 weeks. And this is here at 19 weeks with the linear probe. You see how clearly you can see this confluent vein behind the heart. And by adding color Doppler, you may see also that these are coming together. And from here, it can go up into the upper thorax or down across the diaphragm. So you see here how it could look like. So theoretically, many people are using color Doppler to recognize the normal connection of the lung veins. But is it as easy as it seems to be? No. Why? The main mistake, and this is what I want to point to in this talk, is that many are lowering the PRF and the filter, and they think that these veins are entering the atrium here. But this is a false negative. There's a lot of gain. You should reduce the gain. And this is the same preset, but with a lower filter, higher filter and lower peak. And you see that they are not entering, but there is still a very, very narrow membrane here. So when you are looking to the veins, and they are not separately, but merging almost together, lower the gain in order to get let's say, a false negative. Now, if we go for the different conditions step by step, for the cardiac type, you check from the confluent vein, but you should check for either dilated coronary sinus or the site of connection. So I will show you one case we published a couple of years ago. There is here a dilated coronary sinus. We heard that this is a typical sign for left superior vena cava. We go for the three-vessel trachea view, but there is no superior vena cava in the three-vessel trachea view. What is leading to the coronary sinus dilation? This would be something different. But you see that behind the heart, we have here an azygous vein. It means we have a venous anomaly, so we'll check for the veins. And then you see that behind the heart here, we have the confluent vein. And in the next plane, this is draining into the coronary sinus, leading to its dilation. And this is the cardiac type of coronary sinus connection. So the supracardiac type, you will look for the confluent vein, and then you check to recognize a vertical vein going to the up with flow from the heart toward the upper thorax, which is not existing actually at the venous level, and a dilation of the brachiocephalic vein or innominate vein, because the whole blood of the lung will pass through this tiny vessel, and this is why it's important to know this condition. So what you'll do here, you'll check for in a longitudinal view to recognize the vertical vein. And this is here on the dilated brachiocephalic vein. You see, look at this video clip, and I'm trying to look at the great vessels, but there is something here disturbing me. There is some vessel here which is not, should be there on the left side of the pulmonary artery. And if you go to the upper thorax, you see the dilated brachiocephalic vein, an important hint for the supracardiac type. And for the infracardiac type, I think it could be easy to think about, because you need to get a longitudinal view. As a hint for you, try every time you suspect a cardiac defect to do a Doppler of the ductus venosus, because you get a longitudinal view and you see that there is an additional vessel going into the abdomen and not only the aorta. And this is here how it looks like. And I think it's a question of time that we may see it even early gestation. So this is here going from the heart toward the diaphragm, so, toward the liver. So if you try to get the vein, then you can see it so clearly. One point I just explained to you before, that you can, if you have suspicious, you can look at the pulmonary veins, Doppler. The normal shape looks like ductus venosus, and in cases abnormal, they have an abnormal shape, and especially when they are infracardiac, they have a continuous flow, which is unusual for this condition. So I come to my conclusions. take-home messages I want to give you is, first of all, check for this condition if you have an isomerism you suspect, especially right isomerism. If you find the heart in the right chest, either dextrocardia or shifted, it can be associated with abnormal pulmonary venous drainage. If you find a cardiac malformation, it should be part of your workout for this condition. And if you have any doubt, check the area behind the heart and try to use routinely color Doppler in a longitudinal way to see the upper or lower vessel, and to use pulse Doppler to get the abnormal pattern in these conditions. So I hope in a few years we'll have better detection rate, and I thank you for your attention.
Any question from the floor? This is a very interesting talk because it is important. Anyone, if you have something to say?
Can I just ask a question?
Yes, go ahead.
Do you think we have any hope of getting general sonographers and sonologists to get better at identifying anomalous veins?
The question, yeah, if we can get general sonographers, yet from 2 points of view. The first one is by detecting a cardiac abnormality, like any venous abnormality could be a hint. And the second, probably we should implement the area behind the left ventricle, between the left ventricle and the descending and in the spine as a hint, because if people do not know how the abnormality could look like, they will never detect it. We were focusing only on saying, look at the veins entering the atrium. So you turn the gain until you see something entering, you say it is done.
So you think looking at the distance between the left atrium and the aorta
I'm not
might
sure
give
because,
people clues?
Yeah, let's say this was proposed, but it is not, it's a retrospective. But I think if they know that there is something black behind the left atrium, it can be of big help.
It was certainly present in all those beautiful pictures you had.
Thank you.
Could I have one comment?
No.
One small comment for the audience. Because, of course, you had no choice, you have to go fast. And you mentioned, of course, isomerism, which is an important factor in terms of abnormality, always an abnormality of the venous return, specifically cases of right isomerism. And I can tell you that when you have a case, and our helper is there, our echographer is here, when we have a case of potential isomerism, half of the audience of fetal cardiologists, we are 6 of us, 3 will say it's the left, 3 will say it's the right.
Okay.
It's not easy. Just to say that if you can at least realize that there is one single atrium, that is one step, and let us, try to find out if it is the right and left, because in the right it's not the same shape. But it's very difficult, very difficult.
And the shape of the atrium, is more circular and not this irregular, what you see in normal
absolutely, but it's not that
connections.
easy. It's indeed.
Let's hope. Thank you, Dr.
Very good.
Thank you.